This morning, I'm pleased to introduce Dr. David Aronoff as today's keynote speaker. Dr. Aronoff is the director of the Division of Infectious Diseases at the Vanderbilt University Medical Center and holds the Addison B. Scoville Jr. Chair in Medicine there. He received his Bachelor of Science degree in microbiology from Indiana University and his medical degree at Tufts University in Boston. He completed training in internal medicine at Vanderbilt University and stayed at Vanderbilt to complete a clinical fellowship in infectious diseases and a research fellowship in clinical pharmacology. Dr. Aronoff then joined the faculty in infectious diseases at the University of Michigan, where he also completed a research postdoc fellowship in immunology. He returned to Vanderbilt in 2013 as director of the Division of Infectious Diseases in the Department of Medicine, with secondary faculty appointments in the Department of Pathology, Microbiology, Immunology, and the Department of Obstetrics and Gynecology. He also holds an adjunct faculty position at Meharry Medical College and an honorary appointment on faculty at the University of Witwatersrand in Johannesburg, South Africa. Dr. Aronoff has been elected as a fellow in both the Infectious Diseases Society of America and the American Academy of Microbiology. Apart from responding to a pandemic, Dr. Aronoff conducts research to better understand infections that complicate pregnancy. Dr. Aronoff has been highly involved in the diagnosis and clinical care of COVID-19. He has been a key communicator of public health measures during the pandemic through frequent media appearances, educational activities across the region, and direct relationships with employers. SVC got to know Dr. Aronoff late last year when on several occasions he provided our SVC Executive Committee and Board of Directors some timely guidance on the status of the COVID virus and some perspective on the feasibility of a live 2021 TechCon. Some of you may have seen copies of his outstanding presentations he made to us that were circulated to the membership. Once again, I want to thank Dave for his sage advice to the Society on this subject. We look forward to your presentation, and you're up, sir.
Ed, thank you so much. It's such an honor to be able to present to you all this morning and to join SVC TechCon, even though it's remote. And I know that the plan had been to be in Nashville, and I would have loved to have joined you all here in Nashville, Tennessee, and hopefully in the future I can meet you. I'm going to go ahead and get started. I really appreciate that great introduction. I'm going to start by telling you a little bit about my own roles in the pandemic, and then focus on some of the lessons that we learned after level setting us in terms of where we are today in the pandemic. I'll discuss what we've learned in brief about the virus, about the disease, about how the disease is transmitted, and what we're doing to treat patients with COVID-19. I'll focus on our efforts in disease prevention and vaccinations. And I will touch briefly towards the end on the emerging problem of variants or mutants of the SARS-CoV-2 virus, and then finish briefly with really a single slide about where we might be heading. So since the pandemic began, I've obviously taken a big interest in this as an infectious disease specialist, but it really became a reality for me when COVID-19 hit Tennessee in early March of 2020. Since that time, we've hospitalized thousands of patients here at Vanderbilt, and I've been involved in the daily care of our COVID-19 patients throughout the pandemic thus far. We have our own internal set of treatment guidelines that I help to craft and update. I've been lucky to be involved in research projects around COVID-19 and just managing a lot of teams that have had to respond to all sorts of different aspects of this pandemic. And then the way that I really had the great fortune of interacting with SVC and its leadership had to do with my roles in communicating and trying to help businesses and other parties like schools and community groups learn what we know about the pandemic in real time to help keep people safe and help people make best decisions to keep themselves safe, or in the case of businesses or other groups, their patrons or members safe as well. It's given me an opportunity to really communicate a lot and strategize with many businesses located here in Nashville, but some that are national and international. And it has given me a new appreciation for the ways that infectious diseases and public health can really be disruptive to our economy and really rely during a crisis on partnership between academic public health and the private sector. And these are some of the groups with which I've been really honored to work, including SVC. So where are we today? And by today, I mean sort of in recent days, as opposed to where we began. And globally, the disease is still very active. In fact, there are over 30 countries worldwide that are still experiencing daily increases in COVID-19 activity. There have been at least 150 million documented cases of COVID-19, and we are approaching 3.5 million lives lost from this pandemic. And you can see these curves of new infections and reported deaths dating back to the beginning of this pandemic at the end of 2019. And you can see that we had a peak in the winter of last year that then really started climbing again, and deaths have been doing the same globally. In the United States, things are a bit better right now. We've still made the diagnosis of COVID-19 in about 10% of the US population, around 32 million people, and over 500,000 lives have been lost from COVID-19. These are excess deaths over and above what we experience year over year in our country. If we look at new infections, we really did have a major peak at the end of December, and that dropped precipitously in January, February, but then we started to see another increase in March and April that has been coming down again. Vaccines became available for the first time in early to mid-December of last year, when the Pfizer mRNA vaccine was the first to get emergency use authorization. We've also seen a decrease in deaths that had a recent increase and now has been leveling off. The leveling off is likely a result of getting lots of people vaccinated and continuing to work to have people protecting themselves through what we might call non-pharmacological interventions, things like social distancing and wearing masks, etc. I could spend hours, and I won't, talking about all the lessons that we've learned during this pandemic, which hopefully put us in a situation where this won't happen again, at least not on our watch. And I wanted to go through some of the things we've learned specific to COVID-19. First is the damage and destruction that can be caused by such a simple virus. This is really a simple structure. The virus SARS-CoV-2 is basically a shell that's made largely out of protein and lipid. And inside that shell is the nucleic acid, the message that the virus gives to an infected cell to make more virus and turn into a factory making virus. And that's RNA on the inside of that shell. On the outside are these proteins that are really spikes. They look like spikes under high-powered microscopy. And it's those spikes that create the Velcro that allows the virus to stick to the cells in our body and cause infection. But that also means that those spike proteins are the target for our immune system when we are trying to defend against infection. So if we've been infected in the past, our body builds antibodies targeting these spike proteins. If we've been immunized, all of the vaccines that are available are trying to train our immune system to make antibodies against these spike proteins. Then if we get infected, those spike protein antibodies are there to bind up and saturate these spikes, almost like putting petroleum jelly on a piece of Velcro. It loses its stickiness. And that's the basis of how all of these vaccines and monoclonal antibodies work. The disease is so fascinating, and we've learned a lot that we did not expect about a pandemic respiratory illness caused by this coronavirus. Unlike other coronaviruses, SARS the first or the Middle Eastern respiratory syndrome virus, this virus is capable of being transmissible and making people contagious in the complete absence of symptoms. In fact, somewhere between 1 out of every 5 infected people and 2 out of every 5 infected people never have symptoms at all. And unless they get tested, they don't know that they're infected, and yet they can spread the infection. In addition, most people who develop symptoms have mild to moderate illness. It's a minority of people who end up in the hospital and end up dying of the infection or leaving the hospital with significant disability. Being over 65, having medical conditions like high blood pressure, diabetes, obesity, cancer, other chronic illnesses really predisposed to doing poorly with COVID-19. And there are also long-standing systemic health and social inequities that have disproportionately rendered some populations really susceptible to doing badly with COVID-19. If we talk about transmission of this virus, we've learned an awful lot in a short period of time. Initially, we really didn't know all of the facets of transmission, and we were focused a lot on surface disinfection, fearing that the virus could easily be spread from person to person by getting on objects in our environment, like door handles, for example. We learned over time that the majority of cases occur with transmission events through our breath that occur at short distances. Somewhere around 6 feet or closer really increases the risk because of respiratory water droplets carrying the virus. But we also learned that under the right conditions, particularly crowded conditions or poorly ventilated indoor spaces, that much smaller water particles can carry the virus longer distances, and the virus can hover in the air for longer periods of time. And that's more of an airborne or aerosol transmission. We don't think that inanimate surfaces are a major driver of transmission, and that's something that we learned over time. The most nefarious aspect of COVID-19, in my view, is how much of the transmission has occurred and continues to occur silently. People who have no idea that they themselves pose a threat to others are spreading the virus to those other people. And those other people may fare okay. They may not know they're infected, but they could pass it on to somebody who ultimately ends up disabled or dying from COVID-19. And this silent transmission has made public health interventions really challenging, convincing people who are healthy and don't feel sick at all to stay at home, or to watch their distance between themselves and others, or to wear face coverings in public has proven to be a major, major challenge. In terms of treatment, this continues to really evolve. Currently, when we care for hospitalized patients, we use an antiviral agent called remdesivir, which has been shown to accelerate recovery from COVID-19 for patients in the hospital requiring oxygen. For people outside of the hospital, we know that we can give people who are at high risk of getting hospitalized monoclonal antibodies to bind that spike protein and protect them from getting worse with COVID-19. And these monoclonal antibody cocktails certainly help keep people out of the hospital. We also use anti-inflammatory drugs because a lot of the damage caused by COVID-19 is driven by our own immune response against the virus. So medicines like dexamethasone, or fancy terms which have taken me a long time to learn to pronounce, anti-inflammatory drugs like tocilizumab and baricitinib, are also finding use, all of these for hospitalized patients who appear to be heading in a wrong direction or are at high risk of doing badly. On the horizon, we desperately need oral agents that are potent antiviral drugs that can be used before people get really sick, particularly people who are at high risk of getting ill. And I'm happy to note that there are such drugs in clinical trials right now. What about prevention? This has been one of the major areas of learning throughout this pandemic, and the kind of thing where we've made recommendations prior to having a full evidence base to support those recommendations. And some of those recommendations have proven to be quite helpful, and others we still don't have adequate evidence to support. But what is clear and has become abundantly clear is that multiple measures layered together work better than any one measure by itself to slow the pandemic, to do what we've called flattening the curve of numbers of cases that we see every day over time. And I love this cartoon, which was drawn first, at least to my knowledge, by Ian McKay, who's a virologist in Australia, who came up with this cartoon that really illustrates nicely how we try to prevent this virus from infecting ourselves and other people by using multiple risk mitigation measures, none of which are perfect, but each of which can stack together to make the risk of transmission go down. And this is really a great way to think about this Swiss cheese model. You know, staying 6 feet away helps, but it's not perfect. Wearing masks, particularly cloth face masks in public, clearly help. They're definitely not perfect. Hand hygiene and cough etiquette probably help, but they're not perfect, and so on and so forth. All of these things, all the way up to what we think is a major backstop, or that final piece of cheese, which is the use of vaccines, really do help to reduce the risk that the virus is able to move from person A to person B. And some really recent data strongly support this layered approach. So this study, which was just published recently in Science, called Household COVID-19 Risk and In-Person Schooling, essentially addressed the intersection between household adults who had children going to school in person and looking at how risk mitigation efforts in school affected the risk of the adults at home for getting COVID-19. And the question that they asked in this study was, do mitigation factors like the things listed here, mask wearing, spacing of desks, all the things you might think about, do these mitigation factors actually reduce the risk of an adult at home getting COVID-19 if their children attend in-person schooling? And it's a really fascinating, very large study based on a survey that was conducted involving over 2 million recipients of the survey and over 500,000 people who responded who had children at home doing in-person schooling. And what they found is that, maybe not surprising, that living with a child doing in-person schooling increased the risk for an adult at home getting COVID-19 by about 30 or 40%. But each separate mitigation factor, teachers wearing masks or students wearing masks or canceling activities extracurricularly and these sorts of things, each one of these mitigation factors reduced the risk somewhere in the 5 to 10% range. And in fact, daily symptom screening, simply keeping kids home if they didn't feel well, and teacher mask mandates and canceling extracurricular activities were each the most potent of the individual factors. And what they found, which I think is a really compelling case for why we should all enjoy the Swiss cheese of this prevention model, is that when 7 or more mitigation measures were in place, the association between in-person schooling and somebody at home getting COVID-19 disappeared. So let's pivot from that to talk about vaccination. And we can't really talk about vaccination without thinking about herd immunity. And herd immunity refers to the percentage of a population that needs to have some immune protection against the virus to end the pandemic. You know, if I'm infected and everybody around me is immune, that virus isn't going anywhere. It doesn't have a chance to spread. And we think that somewhere around 70% or greater of our global population needs to be immune to end the pandemic. And that's also true in countries or in certain regions where we really need about 70% or higher of the population to have immunity. And so far, vaccines are the safest and most effective way to get us there. We have 2 mRNA vaccines right now in use in the United States and 1 adenovirus vector vaccine. let's talk a little bit about herd immunity and put, I think, a nice graphic to it. Early in this pandemic, you started hearing about this term called the R0, or R with a little zero subscript in front of it. And what that refers to is the average number of people who get infected from a single infected person. Now, this is just an average, but if we remember back to the beginning of the pandemic, our best estimates for SARS-CoV-2 is that it had an R0 somewhere between 2 and 3. So I've drawn here what it looks like to have an R0 of 3, which means on average, this one infected person will infect 3 people. And each of those 3 people will infect 3 people. And so now there are 9 new infected people, and they will each go on to infect 3 people, and so on and so forth. And so by the time you've gotten through 6 cycles of infection, you have over 1,000 people infected, starting with this one individual. And this is how you get a pandemic. And this is exactly what happened with SARS-CoV-2. But this R0 is not a fixed element of a virus. In fact, you could have a person who decides to just stay indoors in a room by themselves and never interact with anybody, and they won't infect other people. Effectively, for that one person, the R0 is 0. But we did learn that if we asked people to keep their distance, to stay at home unless it was absolutely necessary, and to wear masks in public, we really could drive this R0 at the population level closer to 1. What does that mean? That means that for every infected person, they go on to infect another person. And that means after 6 rounds of transmission, you've got 7 people infected instead of over 1,000. But that still is enough to keep the pandemic going, particularly because there are still the occasional people who get into an elevator and sing at the top of their lungs, and they're infected and they don't know it. And they effectively infect lots of people, not just one person. But with vaccination, the idea is to make it so that if I get infected with SARS-CoV-2 and I'm vaccinated, I might still be able to be infected, but I'm much less contagious because I'll clear the virus faster and I'll shed less virus. And so, first of all, as this infected person, I'm less contagious. But if people around me are vaccinated, it is also harder to infect them. And that helps drive this R0 less than 1. So if I get infected, I'm actually unlikely to pass the virus to somebody else. Unfortunately, right now in the United States, vaccination rates are dropping. They peaked at about 3 million vaccines a day, and they're now closer to 2 million vaccines a day. Yes, about 45% of the US population has started the vaccine protocol, and about 1/3 have completed it, but that's not where we need to be to end the threat of COVID-19. It can be modeled to see how long it will take us to get to, say, 80% or 70% of the population in the United States vaccinated. And if you look at this green line, as of May 5th, about 45% of the population has started vaccination and has some immunity. And if we continue at this pace, we won't get to 70% until mid-August or 80% until the end of September. And you can see from some of these gray lines that we were on track to get to 70% in June and 80% in July. But it has fallen off as the rate of vaccination has fallen. But vaccination is really important. First of all, it allows us to protect ourselves. Vaccines absolutely make it harder to get infected. And if we get infected but we're vaccinated, we are much less likely to get symptoms. And even for young, healthy people, losing your sense of taste or smell can really be devastating. And it may last for a long time, if not indefinitely. Developing brain fog is not something that people enjoy, but can happen to previously healthy people. And of course, there are people who get hospitalized and die, and these vaccines absolutely protect against that. On a personal level, they're very protective. But as I mentioned, we really have the capacity to step up and form a human shield that makes it hard for this virus to find a vulnerable person to infect. The vaccines clearly reduce transmission risk, and we can each play a role in this, because if we happen to get infected but we're vaccinated, we're less contagious. And that's really important when we're trying to drive that R0 down as close to zero as we can. We've now vaccinated millions of people in the United States. Well over 200 million doses have been given of our vaccines. They're very safe and they are incredibly effective. There's lots of myths out there. First of all, vaccines do not cause infertility. Our experience thus far really does establish a safety track record in the setting of pregnancy and breastfeeding. I've been taking care of patients who have COVID-19 and are pregnant, and it is so horrible to watch pregnancies get lost because of stillborn babies that occur when someone gets very sick with COVID-19. It is heartbreaking to watch a pregnant individual die of COVID-19. These vaccines are preventing those deaths, and they are really helpful. Yes, there are rare cases of anaphylaxis with the mRNA vaccine and severe blood clots and low platelets with the adenovirus vector vaccines, but these are really rare, and we have good ideas of how to risk mitigate against those risks. Long-term health effects are highly unlikely. We have not seen any thus far, although we have only been using these vaccines for about a year, and millions of people have now gotten these vaccines. I want to finish by talking a little bit about variants. You know, viruses that are simple and replicate rapidly are prone to making errors when they copy their nucleic acid, and that can introduce structural changes to the shell or the spike protein. That's a natural part of evolving that happens, and most of the time, these changes don't do anything to help the virus. But occasionally, we've seen the eruption of modifications to the spike protein that make it so that the virus is stickier. It's able to infect us better. It's able to replicate to higher levels in our body and make us more contagious and make us more sick. And we've seen variants arriving from all corners of the earth, and some of them appear better than others at even evading the monoclonal antibodies or not being quite as well covered by our vaccines. Although to date, our vaccines are producing protection against these major variants that are circulating. But if we look in the United States as of mid-April, and we look at the proportion of virus that is made up of these different variants, and here's a bunch of bars from various dates dating back to January to mid-April. And this big yellow chunk is showing that the majority of virus in the United States is now this highly transmissible variant that was called the UK variant, the B117 variant. And this is a good reason why we really need to get vaccinated, because vaccines do protect against this and other common variants. So in the meantime, we need to continue doing the non-pharmacological interventions. Watching our distance really does help. Avoiding crowded, stuffy, poorly ventilated indoor spaces helps. Wearing masks helps. Getting vaccinated helps a lot. And in fact, very recently on May 5th, a study came out in the CDC's journal, MMWR, that modeled how we're going to get out of this pandemic by combining vaccines with these other interventions. And a great quote based on their data, and I urge you to look at the modeling in this, is that high vaccination rates and compliance with public health preventive measures are both essential to control the pandemic and prevent surges in hospitalizations and deaths in the coming months. What do I think about the future? Well, I think we're going to get global control of COVID-19, and we're going to continue to rely in the future and on present on a lot of surveillance. Global virus surveillance, sequencing, and data sharing are going to be important. Less expensive, easy to get over-the-counter testing will be crucial, particularly as we look for recurrence of this pandemic. Having treatments that are inexpensive and accessible, as well as vaccines that are widely taken up. Getting children immunized, being prepared for boosters. I certainly would stand in line to get a booster shot every year if it kept us from repeating the last 15 months. We also are now facing the disabilities of people who have recovered from COVID-19. I didn't have time to talk about long COVID or post-acute sequelae of COVID, but that's a big issue. We also need to improve our public health systems to be prepared for future pandemics, and we need our populations to be more healthy so that we're less vulnerable. to threats like this. I want to close by thanking all the providers at my Vanderbilt University Medical Center, the patients who I've had the luxury and privilege of helping to care for and their families. I want to thank you, all the membership and attendees at SVC TechCon and the leadership for inviting me to participate. I am happy always to engage in questions. That's part of how I learn for sure. I'm also on social media if you're easily bored. You can see me on Twitter. And with that, I will close.